From Sarasota Memorial and the Deb Kavanaugh Multimedia Studio, this is HealthCast, a healthy dose of information from experts you can trust.
Hi everybody, welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us today as we talk about anesthesia and aging. Our guest today is Dr. Matthew Waldron, Department Chair and Medical Director of Anesthesiology here at Sarasota Memorial. Dr. Waldron, thank you so much for being with us.
Thank you for having me. I'm excited to be here and talk about this important subject.
So let's start with the basics. Are there different types of anesthesia which can be used for different populations based on things like age?
Yes, absolutely. I think first and foremost, we're having this conversation because there's been an aging of our population. In the last decade or so, we've had 33% growth in our older patient population. And this has become a very important subject and a heavily researched subject in anesthesia because of an aging patient population. There are different types of anesthesia. Anesthesia can be as simple as the local anesthetic that you get at your dentist or in an office. And it ranges all the way to general anesthesia where you have a breathing tube and we manage all of your hemodynamics and your ventilation during a surgery and kind of everything in between. So there's a wide range that starts with local and goes all the way to general anesthesia. And we try to fall somewhere on the paradigm or on the scale depending on the type of surgery you're having, your age, and some of your comorbid conditions as you present at your health baseline.
So you talked about the growth of this aging population. What are some of the challenges that can be faced by this population when it comes to anesthesia?
The biggest thing that we find that is important to us is kind of as you age, your body changes significantly. And it starts from the top down. Your brain matter, your gray matter and white matter in your brain will shrink. The amount of CSF that your brain floats in and that your spinal cord is surrounded by decreases. Your heart changes. You have a lot more calcification and sclerosis of your vessels, which makes them less compliant or able to adapt to change. Your heart output depends more on volume and less on other factors. Your lung volumes will decrease. The amount of air exchange that can happen in any single breath goes down. Your kidney function will start to slowly worsen as you age. So there are a lot of things that go into aging when it relates to anesthesia.
Are there any additional risks when it comes to anesthesia for an aging patient? And what are the potential side effects of the different types of anesthesia you discussed?
That's a really good question. There are a lot of things that kind of determine risk. Obviously, the most important thing is kind of what your health baseline is and where you're starting from. Your age, independent of any other factor, is kind of the biggest risk factor for patients. The older you are, the greater the risk of undergoing anesthesia. That is based on a lot of the physiologic changes that we just discussed. And your body is less able to handle stress. And we like to consider anesthesia similar to the stress of vigorous exercise. So whether it be running on a treadmill or riding a bike for several miles, that's kind of the stress that your body will undergo when you have anesthesia. So age is the most important independent risk factor. Other issues as you age, your ability to tolerate medications goes down, your ability to process and metabolize medication go down. So all these factors kind of contribute.
Can we talk about anesthesia's impact on cognitive abilities? Because that's such a huge topic that we hear a lot from our aging patient population.
Yeah, so when we're talking about the spectrum of deep sedation or general anesthesia, there is a lot of new data that's coming out that says anesthesia isn't necessarily great as you age because of the physiologic changes your body goes through and the stress of the procedures themselves. The more anesthesia you get, the longer the duration, the more concentrated the anesthetic required, the worse or the higher risk you are for having a complication. There are things that we can do to isolate and try to reduce some of those independent factors. The most common type of issue related to aging and cognitive dysfunction is delirium. Delirium happens in up to 65% of patients, depending on what study you believe. And that's all comers for anesthesia, but mostly related to general anesthesia or really deep sedation. That's where people will be a little confused, a little forgetful, maybe not remember where they put their car key or remember who somebody is for a short period of time. Usually this will last only a couple days and will get better over time. There is a subset of population who has initially some delirium who will go on to persist and have postoperative cognitive dysfunction. Postoperative cognitive dysfunction is a longer acting condition which sometimes never improves. We're always hopeful that it will. This is usually somewhere in the range of 10 to 15% of patients will have persistent postoperative cognitive dysfunction. And the worst part about it is it's not really well understood why it happens. There's a lot of theories. Is it inflammation? Is it less ability to handle stress? Is it creation of reactive oxygen species due to the stress? Is it just purely an inflammation thing? Or is it actually you undergo some apoptosis or cell death as a result of the stress? So there's a lot of different things that are proposed, and that's kind of the continuum. Everybody after anesthesia will have a period of waking up, being a little confused, not knowing where you're at, things like that. But when you take somebody out of their normal routine and you bring them into a hospital and they're in the OR and it's, there's no sunlight, you lose lose track of space and time for a short period of time. Older people have a harder time adjusting to that and kind of finding their baseline. So it's definitely possible.
So for an aging patient looking to have a medical procedure for whatever reason, what might be done to determine what type of anesthesia is actually best for them and if they're a good candidate for anesthesia to begin with?
Yeah, so first and foremost, the biggest determinant of what type of anesthesia you'll receive is what type of procedure you're having. This can start at, people need endoscopies, screening colonoscopies and endoscopies as you age. And that's more of a sedative type anesthetic where you breathe on your own. We give you some sedation to keep you comfortable. But the procedure will dictate a lot of what's decided. If you're pregnant or having a child, there will be more often an epidural or a spinal anesthetic that's delivered. And that's because these are kind of the vetted, safest way to do these things, and that procedure dictates what type of anesthetic you'll have. The last is kind of invasive surgeries. Will require general anesthesia. General anesthesia is, total loss of sensation, of feeling, of consciousness, where we do most of the work. Your body rests, and we go through the operation that way. So a lot of times it will be determined by what surgery you're having. That changes over time. Now we do a lot of injections or numbing of extremities for orthopedic surgery, so we don't have to do as much of that. We're doing more and more catheter-based medicine where we can provide analgesia through different catheters and epidurals for procedures. So it's kind of always evolving, but the biggest determinant of what type of anesthesia you'll have is what procedure you're having.
So what might prohibit a patient from having anesthesia altogether, where their surgeon or an anesthesiologist might come to them and say, I don't think this is right for you?
Generally, if you need a procedure that requires anesthesia, there will be a way to get the procedure done. All procedures and all evaluations come with a risk assessment of what the risk is to each patient. And those risk factors are sometimes fixable before surgery, or you can mitigate them, and sometimes they're not. I like to say at the end of the day, if anybody comes in for emergent surgery, we provide anesthesia. So there's not really a strict contraindication for anesthesia. I think that the newest conversation is, how do we get people who aren't necessarily optimized ready for surgery? And that should start in each clinician or surgeon, physician office. You have to look at the patient's risk factors. What is their baseline? Is there ways that we can improve patient outcomes by being more proactive going into surgery? So there are contraindications for each type of anesthesia independently. If you're on blood thinners, you can't have spinal anesthesia, or you have to stop them. If you have eaten a big meal in the morning and come in for surgery, hey, that's probably not the best option for you because we need you to be NPO so that your stomach is empty, so we reduce the risk of aspiration. But the biggest conversation we need to focus on now is the concept of prehabbing patients for surgery. This has been relevant in cardiac surgery realm for a while, but this is taking a look at their baseline health status and what can we do to improve them. Are they obese? Can we lose weight? Are they getting a little bit older? Have we done a mental status examination on them, or a small mental status examination to see what their baseline cognitive function is? Because there is a lot of unrealized minimal or mild cognitive dysfunction in older patients that, they get along okay. They're not seeing a neurologist. They haven't been diagnosed with, any sort of specific type of dementia, but their cognitive function has started to slip. For those patients, having them eat healthy, having them getting active and exercising, quitting smoking, reducing their alcohol intake. There's now data that, we can have patients do, cognitive exercises, puzzles, math problems, to improve their cognitive function going into surgery. Now, just because those things are options, those are all time-consuming, have to be driven by the patient at home. They have to be actively engaged in doing those things. And so even if these things are offered, there have been centers who have reported as low as 17% participation in, following the prehab schedule, because it can be rigorous, it can take a lot of time, it can be a little confusing. So I'd say that's kind of where the majority of research is occurring right now, is kind of looking at what can we do for patients before they come in so that we don't cancel them, number one, and number two, so that they come in and they thrive after surgery.
Can you also discuss, for an aging patient who might be listening to or seeing this podcast and saying, well, this all sounds like maybe I shouldn't have surgery, or maybe I shouldn't undergo anesthesia, what conversation should they be having with their physician to make sure that the risk-benefit analysis is there, that it's worth the procedure for them?
Yeah. I think first and foremost is you have to look at what sort of timeline are you on to have this operation. Is this something that needs to happen sooner, or is this something that can wait? And then once you've determined what timeline you need to have this operation or procedure on, then you need to start to think about, what can I do to optimize myself, number one. And then you have to have a real conversation about the risks. We have to talk about the things that have changed in your body as you've aged and why you're less able to adapt to the stress of anesthesia. But we also need to have a conversation about, these are real risks. As you get older, the risk of having a stroke-related anesthesia goes up. The risk of having a heart attack-related anesthesia goes up. And those are real risks. But I think it's important to know that anesthesia is very safe. We talk about risk mitigation, and we're talking about reducing risks of fractions of percentages usually, or single-digit percentages. We're not sitting here trying to say that anesthesia should be scary. Everybody has anxiety related to loss of control, or going under anesthesia, or having a breathing tube. Those are anxiety-invoking conversations that we have every day. You start talking about breathing tubes, and people are like, "Well, wait a second. What do you mean by that?" So, it is not a good feeling to have to worry or think about anesthesia. But anesthesia overall is incredibly safe. We're doing upwards of 2,000 anesthetics a day here at Sarasota Memorial Hospital, and most of our patients do well. Our job now is to try to figure out what patients aren't really thriving after surgery, and how do we make that better.
For those patients who are not medically cleared for anesthesia right away, let's say those cardiac procedures that have a lot of pre-testing done, that you mentioned, are there other options? I know you said that for someone who needs a procedure, they're going to get it done. What are the other options presented to them, or is it a different procedure altogether?
Yeah, so I think the reason people are generally delayed from a procedure is an evaluation to stratify them as what their risk is going into the procedure. A lot of times during inpatient stays, we'll find things that need to be fixed, which will give you the best outcome if they're fixed prior to anesthesia. So there aren't really absolute contraindications to anesthesia. Even patients who have genetic conditions, there's usually a way to safely provide an anesthetic. I think that most of the delays that we run into when we talk about anesthesia are, how do we make sure that you're as good as you're going to get going into surgery? If you come in short of breath and you have heart failure, but you really need to get your gallbladder done, it's our job as physicians, nurses, nurse practitioners to make sure that you go into that surgery with your heart working as well as you can. And if that means you have to wait a week and get some fluid taken off or need to be put on medication to best support you through that operation, we will do that.
Can you discuss the expected recovery from anesthesia for the aging population? You mentioned that they might have some initial delirium, but what should recovery look like in the days and weeks after?
That's a good question. I think that, again, not to be, kind of obtuse, but it really will depend on what procedure you have and what type of anesthetic you have. If you have some sedation for a colonoscopy, you'll be a little bit sleepy for the remainder of the day, generally speaking. We ask you not to drive just for your safety, but by that evening, the next morning, you should feel 100% recovered. If you have a 7-hour surgery that requires, a lot of intervention, it's going to take you a couple days to recover. And the older you are, the longer it will take to recover. We will automatically adjust your medication dosages, the amount of anesthetic you're given. We will selectively reduce your narcotics and try to reduce drug interactions. But irregardless of what we do to try to mitigate some of these things, just long procedures are less desirable the older you get.
Is there anything else you want to add for the senior patients preparing for a surgical procedure who might be listening to this today?
Yeah, I think the most important thing to get across to these patients is you can do more the weeks leading up to surgery than we can do the day of the surgery, the day after the surgery. The more effort you can put into doing the prehabilitation things, the eating well, the controlling your medications, the making sure you follow the guidelines that we ask you to follow, the practicing mental acuity, doing those things will help you have a better outcome than anything that I can do on the day of the procedure. If your diabetes is well controlled going into surgery, you're going to do much better from a recovery from anesthesia and the surgery standpoint together. If your blood pressure is well controlled and you follow the regulations and you hold the right medications, then there's less likelihood that we're going to have to give you more medication to support you. So the things that you do leading up to surgery are way more important than the things that we can do the day of surgery. And we can do a lot. We can give you a lot of different medications. We can focus on a lot of different areas. But most importantly is take care of yourself, prepare yourself for surgery, and come in, in the best shape you possibly can.
Makes sense. I do want to briefly touch on the other side of the age spectrum. Are there special considerations for pediatric patients undergoing anesthesia for any reason?
Yes. I think it's a very important subject. We have a ever-growing pediatric patient population, and we are seeing more and more kids who need surgery. I think the biggest thing about pediatric anesthesia and pediatric surgery is, speaking to the parents and letting them understand what we're doing, why we're doing it, making sure the parents come in prepared for what the procedures are going to look like and what they can expect. So, most kids do not like coming to the hospital. They get extremely anxious. They get extremely attached to their parents. They get very shy when you go in to talk to them. We've hired multiple pediatric trained anesthesiologists to try to improve, some of our current techniques and some of our technology here. And it's a growing endeavor for us. But, the parents are kind of where it starts, reassuring the patients that, everything's going to be okay, being helpful. Can we get an IV started? Can you get the kid or child calm enough to have an IV started? It goes a long way as to what we can do if they have an IV. Know that there's a good likelihood that we're going to have to give your child some medication to help relax so we can get them back to the OR safely. And then to know that, generally speaking, we don't really take patients' parents back to the OR. It is traumatic for the patients. It's traumatic for the parents. You have to trust that we know what we're doing. We're looking out for your child. We are not trying to harm your child, but, kids can get very hyperactive when they get stressed, and our job is to try to mitigate that stress. So for those reasons, it's best that you allow us to take care of your children and know that we're going to give it our very best effort and that we will take very good care of them.
And is it similar where a specific type of anesthetic is used for specific procedures?
Yeah, so a lot of pediatric surgery that is done here is ENT. For those, a lot of them will just use a mask over that covers the nose and mouth, and we help support their breathing while they do the procedure for ear tubes. Tonsils, we have to put a breathing tube in, and age is kind of the biggest determinant of that. And when I say age, I mean physical age, but also developmental age. We do have to be cognizant that not everybody matures at the same rate, and we try to take that into consideration.
What else should parents know specific to pediatric recovery when it comes to anesthesia? What should they look for in their kids?
Yeah, I think number one, know that we are going to get you back to the recovery room as soon as we feel like it's safe and that you're going to provide reassurance and support to your child. Number two, kids wake up sleepy just like adults do. They need time to process and metabolize and get rid of the medications that we've given them. And number three, you have to have realistic expectations going into it based on what type of operation your kids are having. Ask the surgeon questions, what can I expect as far as recovery? What can I expect as far as how long the procedure will be? Generally speaking, the longer you have an anesthetic independent of age, the longer it takes you to recover and be fully functional. If you're having procedures that are simple, you're not going to need a lot of narcotics. So kids are going to be much more awake, alert, and oriented. Sometimes tonsils need pain medication so that they can be more comfortable, and those are a little more sleepy. I think that you can expect a quicker recovery the younger the patients are. And if you're not seeing that recovery, then we're happy to answer questions. Please give us a call. Fortunately, kids don't generally have a lot of health problems. And so if something's abnormal, we want to know about it.
Dr. Waldron, thank you so much for joining us today and answering this wide variety of questions.
Absolutely. Thank you for having me, and I hope this is helpful for our patients, for the community. The point of coming here and doing this is to let patients know that, we want to be engaged with their care, that we want them to be comfortable coming in. We don't want you to be anxious or worrying. There's a lot of work that goes into each patient, each plan. An anesthesiologist will visit with you when you come in, talk to you about your options, go you through your plan, make sure you're comfortable with the plan. And we also want you to be comfortable when you leave. We want to know, how you're doing. We have nurses and advanced care practicing nurses who round on patients in recovery. We'll provide education. We'll go through any issues that you have prior to discharge, and we're available. If you have something that's going on or lingering, please let us know. We can help mitigate some of the side effects of anesthesia. We can answer questions about some of the side effects of anesthesia and how long they might go on. We send people home with information sheets, but not every time does the information sheet have exactly what you're looking for. And we always want to be available. We don't want people to be worried about anesthesia. We want people to relax and enjoy the ride.
Dr. Waldron, thank you so much for joining us today.
Thank you for having me. I appreciate it.
As always, we encourage everyone in the community to visit smh.com to get the latest from Sarasota Memorial. Have a great day.